In this episode, you will learn
the hospital is a finite resource with a finite number of beds. If we break down those walls or expectations, we can reimagine where we provide care for patients, and we can have an infinite number of beds. There are models that insurances will cover that keep patients at the center, minimize unnecessary ED visits, and make it easier for all of us. This is EM Pulse
with your hosts,
Julia Magana
and Sarah Medeiros.
We had a patient that was discharged from the hospital to a skilled nursing facility. The patient realized that that was not where they wanted to be, and so came back into the emergency department. Usually when they come back in, they will be readmitted so that we can help coordinate all of their care. However, we were able to discharge them home with a visit from our mobile unit care at home team the next day. At that time, they realized that the patient didn't have any of the medications that they were discharged with and didn't have any follow-up appointments set up, and spent about an hour and a half in the patient's home getting the right prescriptions sent to the pharmacy, calling the clinics to make follow-up appointments, and really providing that wraparound care that allowed it to be done in the patient's home rather than having the patient be admitted back into the hospital to get placement and get these things taken care of.
Welcome back to EM Pulse.
So today, we're going to move on to the next episode in our multi-part series on taking medicine to where our patients are, instead of them coming to us. Medicine on the go.
I really like that, Sarah. And if you have not heard it yet, take a minute to go back and listen to our other podcasts. There's some really interesting nuggets there about preventative care and also pediatricians meeting patients where they are. It's really kind of cool to see how medicine has evolved.
Yeah, and this next one is probably my favorite idea because it just makes so much sense. And yet it has been hard to imagine in this era of hospital-based medicine to have care at home. So to learn more, we have our own Dr. Kelly Owen. She's a professor of emergency medicine at UC Davis and the ED Outpatient Operations Director. She is also the medical director for Express Care and Dispatch Health.
Welcome, Kelly.
I'm excited to be here. Thank you for having me.
All right, Kelly, we've looked at taking medicine to where our patients are in a couple of different ways. Tell me, from the emergency department perspective, what is home-based care?
So the goal of home-based care is really taking urgent care and medical professionals to the patient's home and allowing them to have treatment where they are most comfortable, as opposed to making them come to us in clinic or a healthcare setting.
Yeah, so obviously we do a lot in the ED, and urgent cares do a lot as well. What types of services fall under this model, and how do they differ in goals and workflows?
So we have been fortunate to contract with a company called Dispatch Health, who provides our services for us. They have 3 different service lines. The first is acute care, which really is an urgent care at home model. And they can do almost everything that a freestanding urgent care can do. Things like suturing, IND, they can give IV antibiotics, they can prescribe medications, they can do point-of-care labs like chemistries and blood counts. The second service line is ED to home, and the goal from there is either to be able to discharge patients that you otherwise would have admitted by providing next day or the day after evaluation in the home, or checking on some patients that may have a high risk of returning, such as an elderly patient with pneumonia. We provide services 7 days a week, including holidays. So it allows for that weekend evaluation, that holiday evaluation that otherwise they would have to wait multiple days to get into a clinic appointment for.
So it's really like an ED follow-up at home.
Yes.
And what's the third line?
The third line is for patients that are discharged from the hospital after an admission. The goal of this line is to help prevent readmissions and make sure that patients are safe in their home. Usually with this, they will go out 2 to 3 days after discharge and ensure that the patient has the correct medications, the right DME, and the right follow-up appointments in place to have their care continued as an outpatient.
I mean, those sound like all very useful things. And I can think of quite a few reasons why we would want to do this. But tell me, Kelly, why did we at UC Davis decide to pursue that kind of home-based care model?
I think the biggest reason is it's the right thing for patients to be able to keep them in their homes. Beyond that, the hospital is very full, the ED is very full. So anything that we can do to prevent ED visits and hospitalization helps keep more space open for patients that don't have this as an option or are too sick to have care at home.
I mean, I think we've all seen those patients that have, quotes, bounce back or came back, and you're like, okay, well, how's it going taking those medicines? They're like, what medicines? Or how is that equipment working? And they're like, what equipment? So having that kind of streamlined thread from hospital to home seems like a successful model, or at least potentially successful model for sure.
Yeah. And, we've talked about express care before with Kelly, and express care can also refer to this service. And so it's another way to get these patients some care at home and some assessment at home, which potentially frees up some space in the ED as well, and maybe keeps them out of the ED.
Yeah, or it supplements what you're doing on an urgent care online virtual visit.
Exactly.
Yeah, I could see that being very helpful there too.
So, Kelly, with that in mind, let's talk a little bit about who is the right patient for these services, and how do we connect the patient with the right service?
So there's not necessarily a right patient for this service. I think it can be valuable for many different types of patients. What we've found in our patient population is that about 50% of patients are homebound. So that is obviously much easier for them to have someone come to them. But even for patients that aren't homebound, it can be very beneficial for the caregiver who can't leave because they have to keep providing care but needs care for themselves. It can be beneficial for children who otherwise would struggle getting out of the house to an urgent care. That's just a more complicated logistical situation for them. So we found it to be very beneficial in multiple different patient populations.
Yeah, and I'll say that sometimes it's just a great convenience for patients. I see patients on express care, and I sort of give them the option of, would you like to go to your local urgent care, or actually you're eligible for our urgent care at home service. And they often much prefer that. They don't have to go wait in a line. They can make an appointment for somebody to come to their house, and it's just a lot more patient-centered.
Yeah. I don't know the official definition of homebound, but I definitely have patients that there's one car for the whole household, and that car is, with their partner while their partner's at work, and therefore can't bring their child in or seek care for themselves.
Sure.
And so I think that would be a large population that's under-resourced as far as transportation goes as well.
And that is a very large group of patients that we're seeing where they just don't have the transportation. They would otherwise be calling EMS to bring them into somewhere.
Yeah, absolutely. We've all seen that. So how does UC Davis actually utilize this home-based care?
We use every service line a little bit differently. In terms of acute care visits, most of the referrals for that come from nurse triage. So a patient calls in looking for care with an acute problem, and then we'll get referred to care at home versus express care versus a clinic appointment. Other ways to get to acute care is our express care providers can also refer to Dispatch Health, as well as our clinic providers can also refer their patients in for acute care. And this can be things like they saw them in clinic on Friday and they want them reevaluated the next day, and so they'll put that referral in. Our ED to home referrals come from our ED providers, recognizing that a patient would benefit from having a visit in the next day. And then as far as patients discharged from the hospital, we are working very closely with our discharge planners to help identify patients that are at high risk for readmission to help target some populations. A great example of that is our patients with congestive heart failure. We know that they are at very high risk of coming back into the hospital after admission. We also know that we're doing a lot with their medications and changing those around. So we are partnered with the cardiology group to follow up their patients post-discharge to help close some of those gaps.
So, Kelly, kind of walk us through who makes up the team. When they show up, what does that patient visit look like?
So we have 2 cars that are in the Sacramento region. They are able to travel in about a 30-mile radius from UC Davis Hospital. And if we go further, then our drive times get longer and we can't see as many patients. So each car can see about 6 or 8 patients a day. They are made up of an advanced practice provider and an MA that go out to the patient's house. They carry with them in the van supplies for suturing, for splinting. They have medications that they can give in the patient's home. They can do IV fluids, nausea medications, antibiotics. The APPs have backup from an emergency medicine physician if needed. And then we are all working together with our connected care center, which is made up of MAs and nurses to help close those gaps between our patients, their visit, and then the health system to get them what they need in a timely basis.
Yeah, so I love this service. Have you actually assessed the effectiveness of this model so far?
Yeah, so we look at data with Dispatch Health monthly. We are seeing about 300 patients a month with them. Patients really love this service. They have about a 94% patient satisfaction score, which is very high.
Much better than our ED score.
Much better than our ED
score.
Only about 2%, 2.5% of our patients are escalated to the ED. So we're actually able to keep most of the care in the home. We are keeping about 83% of patients out from an ED visit by giving their care at home. So really helping to keep people out of the emergency departments. And then for the year to date, we have saved about $4 million in ED visits and hospitalizations while doing the right thing for our patients. So,
wow, that's an amazing saving. And I can see a lot of utility in that. Me seeing utility in it and insurance companies saying utility in it. Our understandings don't always align here. So how do you find funding for a program like this?
Insurance actually does cover most of these visits with the same copay that you would get from either an office visit or an urgent care visit. So from a patient perspective, it's not more expensive for them.
And I imagine from an insurance company perspective, not having to pay for hospitalizations is probably preferable.
Yes. So from a health system standpoint, not having readmissions and decreasing that, as well as just keeping people out of the hospital from the beginning, is beneficial for the insurance companies. This is financially makes sense because they aren't paying for that hospitalization or urgent care visit. And then patients benefit from all of this because it is well covered.
Yeah, that makes a lot of sense to me. And I love a program that pays for itself. Certainly makes it easier to sell.
Yeah, right? But, you know, we're at a huge academic center, obviously. So is this a model that can work in the community?
Yeah, so Dispatch Health works in markets all over the country with different hospitals to create programs to care for their patients. We have created a bit of a unique program with them because we source all of their patients from UC Davis that they're seeing. In other markets, patients can self-refer to Dispatch Health and get their care as a patient-initiated model. We have our patients being either nurse triage or provider referred to Dispatch Health, and they are not seeing anyone else in this area other than patients that we are sending them. So this model can work in multiple different communities, and the amount of involvement and the amount of resources from the health system will vary based on what those resources are and how involved the individual health system would want to be.
So just to be clear, UC Davis has not created its own program. We're not reinventing the wheel, because I'm sure that's a very massive and complex wheel. And so you guys have, or we have, contracted with another team that runs this, but we work alongside them very closely. Is that fair to say, Kelly?
Yes, exactly.
What advice would you give to other institutions or health systems that are interested in designing a similar pathway, especially to those without large resources or academic affiliations?
I think that this program works really well for our patients because we have given Dispatch Health the ability to contact us if they find that something's wrong, or that the patient needs an escalation of care. And so rather than reinvent the wheel, finding someone with the knowledge of how to do this well, and then setting up something within your institution to create specific patient pathways for your most vulnerable patients that allows for that teamwork, I think is kind of key in keeping patients out of the hospital and providing good wraparound care.
Yeah. So, okay, Kelly, I'm going to ask you to tap your expertise and your experience here. How do you see home-based medical care evolving over the next 5 years?
It's not her expertise. It's like into her magic 8-ball.
So I think that as technology gets better, that we really have so many options, especially for remote monitoring. We do have a remote patient monitoring group at UC Davis already that is starting to push those boundaries to figure out what can they do to help benefit patients with, say, high blood pressure and monitor them at home. I think that ideally we would find a group of patients that didn't need to be in the hospital but still need advanced care, and find a way to keep those patients at home and just keep pushing the acuity levels of what we can take care of outside the hospital or clinic base.
I like how the patient is at the center of all of these actions and thought processes. It makes a lot of sense. Kelly, is there anything else you think we should know?
I think this is what kind of the future is, right? Like one way to think about it. So the hospital is a limited resource in terms of number of beds and kind of what you can put within its walls. And as much as we can expand home-based care, it allows for the health system to have a reach and a touch in kind of an unlimited area because patients are staying within their own spaces. So it actually expands the hospital's reach to be able to take care of patients outside of just those walls. And I think that's what's kind of so exciting about it.
Yeah, I love that. And it's meeting people where they are. Honestly, this program has changed the way that I see patients. I was just on an express care shift before this, and I was seeing patients virtually, and it was a huge peace of mind for me knowing that I could send medical professionals out to the patient.
Yeah, I mean, I think it's amazing. I've not used it myself, but I definitely need to look for ways to be able to integrate this into my own care.
Thank you so much to our department for reimagining how and where we care for patients and supporting people like Kelly Owen, who put the patient at the center of every decision.
And thank you to Owen Productions for reimagining how we podcast.
So until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.